The chairpersons for the lunch symposium on HCC, Dr. Manisha Devedi, Dr. A.V. Siva Prasad, Dr. Ashish Kumar, and Dr. Preetham Nath.
Yeah, good afternoon. In today's lunch symposium, there are two topics related to hepatocellular carcinoma. And the first one will be addressed by Dr. Joy Verghese, who will be talking about high-risk screening for HCC in India. Is it a dream or reality? We understand there are so many practical limitations to doing widespread screening. And I think Dr. Joy will take us through these problems and how we can overcome them. Over to you, sir.
Thank you. Good afternoon to all. At the outset, my sincere thanks to the Professor Ajay Duseja and Sunil for the kind invitation. If you take the prevalence as well as the incidence of the HCC in India, even though currently it shows the 3.3 in 100,000 population, if you go through the earlier literature, it showed 2.1. And in HCC, mostly we are diagnosing the very late stage. At the late stage, as we are diagnosing, the mortality rate is very high. The survival will be in the 5 years less than 15%. And now we are looking into that. There is a significant epidemiological shift to the mast cell from the viral serology. So, who are the high-risk groups? What we know earlier, hepatitis B virus groups. If you take in globally, still it's a 42% of the overall HCC groups. And the mast cell mass, nowadays it shows more than 50%. If you combine with alcohol and viral, still it is the number one. It comes around 63.9% in overall HCC population. In India, there are the certain states have higher prevalence, what I showed earlier in 3.3 in 100,000 population. But we all know each state, some of the hotspots, districts are still there. That area will come very higher prevalence than the rest of the other things. So what is the significance of HCC, the surveillance, or we have to do the screening? If we diagnose the HCC at early stage, the 5-year survival goes up to 70% instead of less than 15% if we diagnosed at very late stage. So, advantage of HCC screening, we can reduce significantly the mortality due to the HCC, as well as the stage migration. The early stage of the late, we can control due to the various interventional modality wise, and it also giving the cost effectiveness to the patient. So INASL Puri, the third guidelines, it's 2023, that time, who are the groups we have to involve in the HCC screening? It showed the target population of cirrhosis irrespective of the age and gender, and all chronic hepatitis B and C virus. And the screening, the surveillance, the protocol, not 3 months or 4 months, because there were so many, the data from the various international showed some of them 3 months. So our INASL Puri, the 3 showed the 6-month interval of ultrasonogram plus or minus AFP. And in selected groups, even though it is not B or C virus, it mostly come into that MASH related. The advanced fibrosis, sometimes related to the metabolic liver diseases. That group also should come under the HCC, the screening part. But if you look into that, we know the subject, we know all the things, but practically implementation, that also they commented it, less than 10% of the people are doing the surveillance protocol. So what are the tools we have? Ultrasonogram screening, that will show less than 50% sensitivity. Second, blood marker alpha fetoprotein, that showed only 63% sensitivity. Combination of the ultrasonogram screen and the AIP showed much better, close to 60 to 90% of the sensitivity. But we know the operator dependence plays a major role. Not only that, we can't apply the ultrasonogram or the alpha fetoprotein in the population-based level screening protocol because there will be a lot of the cost involvement and the training the people and the patient, there is a limited infrastructure. So other than the alpha fetoprotein and ultrasonogram, how we can screen for HCC? There are the few validated scores are there. A map indicates age, M for male, gender, and A for albumin and bilirubin, and P for platelet. Keeping this 5 parameter, it is a logarithmic score, we can predict the HCC in a selected risk groups. Other is the page B and the modified page B, the B for hepatitis B patient. So hepatitis B patient HCC screening, we P for platelet, A age, and G gender. These 3 parameters. So these validated scores we can use to the high risk groups without alpha fetoprotein and ultrasonogram to predict the HCC. But what are the things required to do in extensive way? So we need a EHR, electronic health record system wise. We can do successfully. This is the one of the precision surveillance. I initially told alpha fetoprotein per se is a 63% sensitive. So what is the beyond alpha fetoprotein? AFP-L3 and the DES carboxyprotein. These 2 things comes beyond alpha fetoprotein available. The GALAD performance, again, G involves gender. If you see most of the screening protocol, age, advanced age group and gender, male, common it comes because they are groups to get the more of HCC. So G gender and age and the L3 alpha fetoprotein, that is L, A means for alpha fetoprotein, D for descarboxyprothrombin. So using this, the sensitivity almost 63 to 79. Another HES means HCC yearly surveillance. Here they are using only 3 parameter, AFP, L3 AFP and descarboxyprothrombin. Using this parameter, it showed it is much better than things. Liquid biopsy, if you see the circulating, the free DNA and also the microRNA wise, the tumor free, that DNA wise we can diagnose. These all still under the research. The tracer trial, it is still actively ongoing trial to compare the GALAD versus ultrasonogram. So ultimately, these all parameters wise screening protocols are coming. Without ultrasonogram, how we can predict? Initially I showed based on the basic parameter, how we identify predict the HCC here without ultrasonogram. So that trial, this ongoing trial shows the GALAD, this shows almost better than the ultrasonogram wise predicting the HCC. Still there are advanced, the imaging solutions are going. Abbreviated MRI means it is the very short period we can screen for abdomen. The advantage is it should be the cost effective. It will not be an ordinary MRI cost. It will come 1/3. There is a protocol they are changed. Then the AI augmented ultrasonogram. So already the ultrasonogram images everything's already inbuilt that for HCC. So it has to screen and it has to give. The LI rats we know, and the mobile app wise we can screen. These all the way we can go ahead for the population level screening, but it's tough to do the MRI level and the other things. So what the recent guidelines are, even if I have to point it out all the things, but recent guidelines, ASLD, ESL and others, and already I shared the INASL, the PURI, the guidelines, mostly at present based on the two things, ultrasonogram and alpha fetoprotein. The advantage of the AI incorporating in the ultrasonogram or MRI or CT machine and the involving AI in the imaging with the clinical parameter, with the biochemical parameter, it will give the better the sensitivity as well as the specificity. So major the problem drawback, so how to involve the public health integration. We have National Viral Hepatitis Control Program. There is a non-communicable disease level, central government-wise various programs, and it has the telemedicines as well as the community health workers are working more and more. So we have to involve along with for the HCC, the screening in a bigger way to bring down the prevalence and the incidence of HCC in our country. The cost optimization really challenge, but instead of all the population choosing the high-risk groups, we already know who are the high-risk groups, and we have to choose, first of all, the clinical parameter, and we have to go for using the blood biomarkers, then last, the imaging using the hub and spoke models. This all way we can give the better outcome. So the implementation, of course, we can do this to the state level and involving all the other structures as already mentioned. We need to train more and more the people, and finally the quality assessment, everything. So ladies and gentlemen, so the HCC prevalence is keep on increasing. So how we have to give a better the screening or predicting the early HCC. There are so many the parameters, whatever I said, we have to integrate cost effectively. If we give it, it will be the successful model. Thank you so much for the giving opportunity to me.
Thank you. That was a very insightful discussion. You could have a few questions or comments if you have. Okay. Or maybe at the end of his second talk, you can have questions. You can have a seat here. All right.
What is the reason for increased prevalence of hepatitis C infection in India, despite the fact that disposable syringe culture has come in? Secondly, we are doing the transfusion screening regularly for most of the centers. What is the reason? Why, despite that all, we have increasing incidence of hepatitis C virus infection?
I think really that's not something that's part of this discussion. Can we have it at some other time? Dr. Joy, can you please join us?
May I invite Dr. Samir Shah for the next talk, and he'll be speaking about combination immunotherapy for HCC. Dr. Samir, please.
Thank you for the opportunity to discuss today. I start off with a disclaimer for those who do not know me. I am not a medical oncologist. I am just a simple practicing hepatologist, and whatever I have learned and developed expertise in this field of HCC is because of regular weekly tumor boards over the last 10 years with our radiology colleagues, and now since last 6 months I have the opportunity to interact with our medical oncology colleagues and these radiation oncologists. So I think that is something which has given me this confidence of taking up this topic. So why combination immunotherapy? Single agent systemic therapies have failed to significantly improve survival. Sorafenib was approved for use despite all of us saying that there is just a 20% difference in the survival, but in oncology practice, 20% is good enough for a drug to have license for its use. Lenvatinib, slightly better, but nothing great shakes. Nivolumab, there was an improvement, but still, till combination therapies came, there wasn't a remarkable difference for us to see when we are treating patients with hepatocellular carcinomas. So what is the rationale for combining systemic therapies? we have to realize that in tumor growth, there are two things which happen. One is T cell exhaustion, and second is the tumor related immunosuppression. With these systemic therapies, if you combine, then these combination therapies, they prevent the immune exhaustion and they boost the immune response by reversing this immunosuppression. So basically, the tumor which is cold, where there is immune exhaustion, where there is immune suppression, by these combination therapies, you make this tumor hot so that the systemic therapies now can act on these tumors. So how do we combine? So basically, either you can have an immunotherapy with another systemic therapy, anti-VEGF or TKIs, or you may have two immune checkpoint inhibitors. Let us see which are the drugs which are available to us and which are now approved for use. So there are three main groups. One is the tyrosine kinase inhibitors, which all of us were familiar with, sorafenib initially and then lenvatinib. Then the group of immune checkpoint inhibitors came up. And these immune checkpoint inhibitors, there are basically three. Programmed death receptor 1, that is PD1, of which nivolumab, pembro and tisley are the examples. Second is the programmed death ligand 1, PDL1, of which atizo, durva and sinti are these prototypes. Third is CTLA4, cytotoxic T lymphocyte antigen 4, of which EP and TREM are these prototypes. Another group is the vascular endothelial growth factor, VEGF, of which bevacizumab is the prototype. So these are the systemic therapies, and how we combine these therapies is the main sort of topic for discussion today. You will see that I have given different colors to see which are the combinations which are approved for use. So the first one you would remember is atezobeva, which is a PDL1 and a VEGF inhibitor. The second is durvatram, which are two immune checkpoint inhibitors, PDL1 and CTLA4. And third is nivo-EP, which is again PDL1 and CTLA4. So these are some combinations which are already approved for use. Atezobeva, when it first, the landmark study which came up, there was a dramatic difference in the median survival of these patients with this combination. 19 months versus sorafenib. Not only the survival advantage, but if you see the response rates. So if you see the response rates in sorafenib, complete response was hardly anything, less than 1%, while partial response was 11%. So total would be around 11%. In atezobeva, 8% had complete response and 22% had partial. So if you combine the complete and partial response, around 30% of patients responded compared to only around 11%. And 8% had complete response compared to less than 1%. Also, the disease control rate was better and the duration of response was better. So this is atezobeva, which changed the landscape completely, and a lot of new studies have come up after that with different combinations. Durvatram, these quoted as Himalaya phase 3 study, and the regime is called the STRIDE regime. There was a distinct overall survival advantage between either standard of care, which was lenvatinib or sorafenib, compared to durvatram combination. Now we are talking about survival at 4 years. So earlier we were not talking about this advanced HCC surviving so long. So not only there is a survival advantage, but there is a prolonged now survival in these group of patients, and 25% of patients are surviving 4 years in this study. The third combination is nivo plus EP. There were 3 arms which were studied, and the one arm which was noted to have the best effect was Nivo 1 milligram per kg plus EP 3 milligram per kg, Q3 weekly for 4 doses, and then the EP stops and Nivo continues 2 weekly 240 milligrams. So that was the A arm, and there was a 22.8 months overall median survival in these group of patients. Much different from the standard of care, which was lenvatinib or sorafenib. Now, can you compare all these combinations and see what is best for our patients? Obviously, there will never be a head-to-head comparison between these therapies, but if you put all these therapies together on one sort of analysis of the survival curves, you will find, if you focus, that Lenva and bevacizumab have got an early survival advantage. So that is important. The VEGF inhibitors, Lenva, although it is a tyrosine kinase inhibitors, it has got VEGF activity. So the VEGF inhibitors, they do have a early survival advantage. That's the first point to note when you look at all the results. The second point is, if you see Nivo EP, initially there is a lag in the beginning for up to 12 months. But then it's like a lambi race ka ghoda. It then goes on, and it is much better than the rest. So how do you use that? It is important to realize that in all these combination therapies, only 30 to 40% of patients will respond. So almost 60 to 70% will not respond. Now, the important thing is to identify which are the patients who are not going to respond upfront, and that is not possible. There are a lot of biomarkers which are looked at. Nothing has really stood the test of time for us to decide that, okay, this marker is positive, let us start this therapy. This marker is positive, this therapy will not work. That is the type of answers which we need, but unfortunately they are not there. So what markers do we have? We still are talking about, as Joy talked, we are talking about alpha-fetoprotein, we are talking about DCP-PIVKA. So, but this is important. If you have an alpha-fetoprotein drop with Nivo and EP, then you know that you can continue. If the alpha-fetoprotein is rising on Nivo EP, then it is best to switch to another therapy. So that is the lesson which we have learned. Not to keep on going on with a therapy which is not responding. So you don't need to wait for the patients to progress. Just the tumor marker alpha-fetoprotein, if it is not dropping and rising, then you can change from a Nivo EP to a bevacizumab based combination. So that is the lessons we have learned, that early response with VEGF, and second is that if the patient is not responding on your immunotherapy and by the AFP drop, then think of changing before the patient actually sort of stops having a response. So this is combination of systemic therapy. What about combining locoregional therapy, which we are so familiar with, which is either radiofrequency ablation or microwave ablation, transarterial chemoembolization or transarterial radioembolization with immunotherapy? Does it make sense to combine? Yes, it does make sense to combine, because what does locoregional therapy do? It does two things. One, immunogenic cell death, which causes immune cell activation and proliferation. And second is it produces hypoxia, which will cause neoangiogenesis. So if you want to block this, then you will have anti-angiogenetic therapy, VEGF or lenvatinib, which will block this new angiogenesis related to the hypoxia, and immunotherapy to take care of the immune cell activation, which is again caused by the locoregional therapy. So it makes sense that you combine locoregional therapy with immunotherapy. What are the combination? Do we have any results? Yes, already there are studies, the LEAP and the Emerald study of combining TACE with either Lenva plus Pembro or TACE plus Durva plus Beva. So there is a reduced risk disease progression or death by 34% and the progression-free survival by 14.6 months, which is good. We know that if you do TACE alone, you will not be able to achieve this. So it does make sense to combine immunotherapy with locoregional therapy. What about transarterial radioembolization? Again, the same thing. Radioembolization also does the same thing. Even SBRT also does the same thing. So it does make sense to combine transarterial radioembolization or SBRT with immunotherapy, and it has been shown to significantly improve in the combination group the overall survival rate. Very fact that there are so many clinical now trials, randomized controlled trials, looking at either transarterial chemoembolization or radiofrequency ablation with immunotherapy. Not only that, combination of a resection with neoadjuvant or adjuvant immunotherapy, that also has been looked into. All this suggests interest in combining these modalities. Now, at the end of the day, what are we wanting to do? We are wanting to have this advanced tumor to come down and actually give them a chance for cure. And the cure can come only with a liver transplant, because otherwise the tumor is going to remain irrespective of what you do. Cure will be possible if we can achieve a downstaging with immunotherapy followed by transplant. Do we have that in literature? Worldwide, 152 patients only have been done so far. What are the major concerns? There are two concerns. Two concerns with transplanting advanced HCC is that you are worried that it will recur post-transplant. Second is concern of using immunotherapy is that this is immunotherapy. After transplantation, again you are immunosuppressing the patient. You will have rejection. So these are the two major concerns when you are thinking about advanced cancer and transplantation. We have realized now with experience that rejection rates are more or less same, but there can be mortality related to rejection, and the only way to avoid that is to increase the washout period. A minimum of 4 weeks is required, and if you go higher, then obviously the chances are less. Fortunately, with a living donor liver transplant in India, we have the luxury of timing. So we have put up a protocol with the Liver Transplant Society of India of downstaging and then assessing these patients and doing transplantation. We are going to look at what are the recurrence rates, what is the rejection, what is the recurrence-free survival and overall survival. So we truly look forward to this data from our country. So to sum up, the BCLC has changed, but it is going to change much more, and it will be like the Hep C story. The ASLD stopped giving guidelines. They put it up online because they almost changed every year. This is how HCC guidelines are going to be, because with newer and newer therapies, with combination of immunotherapy with locoregional therapy, downstaging to transplant, the neoadjuvant and adjuvant with resection, the guidelines are going to change, and we are in for an exciting time. Thank you.
You. That was a very interesting lecture. Now the talk is open for comments or questions.
Dr. Joy here, right here. This
Joy,
side. Yeah, my question is, when you're looking at surveillance for HCC, biologically, you're not taking into account the different patterns of aggressive tumors versus not. So it's quite likely that on surveillance, you'll only be picking up the non-aggressive, slowly progressing HCCs, and you'll be missing the aggressive, fast-growing tumors. So would we have to factor that also into our consideration when we're doing surveillance? The fact that we are likely to be missing the aggressive tumors and only picking up those slow-growing tumors for which the prognosis is itself better than average.
So So non-AFP secreting tumor or non-aggressive tumor, but the screening protocol wise, here whatever now we have the imaging modality, we are not going to skip the imaging modality, but the question is which imaging modality will be better actually for the population level screening. So ultrasonogram wise, we have to go for the somehow modified, that's why the AE integrated, which will be the more other components we can incorporate. The individual patient's data also, as I mentioned, the age, gender, these are and basic blood parameters, the bilirubin, albumin, because already the validated scoring system is there. So even though it's a non-AFP secreting tumor or the non-aggressive tumor, using this combination might be the better. This the way, so I looked into that way.
No, worldwide, all these organizations, they've always advocated a 6 monthly ultrasound screening with or without AFP. INASL has given up AFP. It's only ultrasound, and the rest of it is a combination. The Japan Society is the best. It includes PIVCA and alpha fetoprotein L1 together with the alpha fetoprotein. So that's a better screening. But you don't have any other protocol which tends to screen in between this 6 month period to pick up a small HCC.
My question to Dr. Shah, sir, your talk was very excellent. So, as we all work in transplant units where our main thrust is to downstage to transplant, what we realize is the non-viral, the MASLed HCCs, somehow their response to atezolizumab, which is the most easily available in India right now through patient support programs, because we also have a lot of cost constraint when we use it from a downstage point of view. Somehow the response rates are not very great. So your personal experience, and once we are not able to downstage with atezolizumab, what is the other strategies where you are using in your day-to-day practice? Because shifting to another immune checkpoint inhibitor probably doesn't have very good data when the atezolizumab has failed. So your experiences, sir.
So initially there were concerns whether viral etiologies would respond better than MASL, but I think in large studies that concern has been ruled out. So that is the first thing. MASL would respond equally well. Your concern about some patient not responding, as I said, 70% will not respond. Now, what do we do? Traditionally, if you have failed first line therapy, then the second line therapy would be a single agent of Durva. But obviously, you are coming down. Although there is no data of switching over to a second immunotherapy combination, I think that is the most practical thing to do. As I was saying, that if you have one combination which has failed, it is not taken for granted that the other combination also will not work well. So I think we should switch if you are not finding any response.
And how many cycles do you give before you assess the downstaging response, sir, in your patients?
So normally 4 to 6 cycles are the usual one. We assess response at 3 months. That is the thing. So too small the number of cycles, we were worried about recurrence post-transplant. Too long a gap, also after stopping, we are worried that the tumor may come back. So the ideal window would be important. So I think number one, we should document downstaging with imaging and decrease in the alpha fetoprotein level. So if you see the Medanta study, I think their thing is if the AFP drops to less than 100, then these are the ones who would respond better if they have been downstage to say within UCSF criteria. These are the criteria which we have used in the multi-center study.
Thank you, sir.
You
For
could
downstage-
always add a tyrosine kinase inhibitor also to this.
For downstaging,
Atezol.
we would also use loco-regional therapy plus
Yeah.
immunotherapy.
Sure.
So both would be
Surely.
better.
I think we had a good discussion of good coverage of both the aspects, right from surveillance to pick up the HCCs and management of the tumors with neo-combination therapy. And thank you to both the speakers for those presentations. And now we hand over to the organizers.